You are now listening to Nailed It, the Orthopedic Surgery Podcast.
All right, welcome back, everyone. This is the Citations Classics Shoulder and Elbow. Today we have a great episode prepared for you on medial elbow instability. Have a lot of the pillars of elbow orthopedics, a lot of the pioneers in that field, some of their original early articles. So good episode tonight. I am Sam, PGY1 at University at Buffalo. Same team as before, joined by Alex Macfarlane, PGY5 at University at Buffalo, Teja Polisetty, MS4 at Harvard, also just recently matched at Harvard for next year, so congratulations to him. Matthew Corsi, MS3 at Wayne State, and Jalen Warren, MS3 as well, at Ohio University. Without further ado, let's get into this episode, though, and get talking about medial elbow instability. We have a great introduction from Dr. Macfarlane.
All right, so we'll just briefly go over the anatomy and then focus on the medial elbow. So the distal humerus, it has multiple, like a three-dimensional variation from its axial or its long axis. But for this particular, you need to kind of know about its 6-degree valgus angle, which gives that usual view of it with your arm standing at your side of that valgus carry angle, on average about 6 degrees, varying from 4 to 8. It also does flex forward a bit, as well as has an axial rotation to it, but that's a little higher level and not really germane to this talk. The valgus stability of the elbow, like really any joint, is dependent on its bony and its dynamic and static stabilizers. So from a bony congruence standpoint, really it's that radial head at the capitellum acting as sort of that buttress in a valgus moment. So you imagine that, stressing the elbow, that radial head abuts the capitellum. Also your common flexor origin, really that FCU, FCR. And that becomes important for valgus stability of the elbow, that, that strength of those muscles is really important, and for not overstressing the medial collaterals. And then that brings us to the medial ulnar collateral ligament complex. So nomenclature can get really confusing here, mostly because we have bands and bundles and MUCL, LUCL. So just trying to focus on the medial here. Big thing is this is, again, the medial ulnar collateral ligament. So it's from the medial epicondyle, really sort of the anterior inferior epicondylar surface, into the sublime tubercle. Now, a lot of people often get this confused, asking where the MUCL attaches. Is it the sublime tubercle or supinator crest? Mostly because we talk about this with the LUCL, and we don't really know which of those bony landmarks is on which side. For me, it's just understanding that the supinator is on the lateral side of the elbow. So the LUCL attaches on the supinator crest, whereas this attaches to the sublime tubercle, or the anterior medial process of the coronoid. A lot easier just to say the anterior medial process of the coronoid, because it makes sense being on the medial side. But you will hear people who, tend to be a little more elbow specialists, or even just, like to use the old terminology using sublime tubercle. So understand too that valgus instability of the elbow is really a unique pathology that only specialized individuals sort of get. So that really the overhead throwers, so javelin, pitching, rarely even football throwing. So it's, go about your day and look at how your elbow is actually stressed. Most of the stress that we put on our elbow is varus, whether that's reaching in front of you, pushing yourself off from a chair, etc. Rarely do you have gravity acting on your elbow in a valgus moment, unless you're throwing something overhead. So I should go back to show that picture. The MUCL is divided into anterior, posterior, and transverse bands. Really, the anterior band is what we're most concerned about. The posterior band does tend to be tight when you're in extension. But the anterior band mostly is isometric throughout its motion. And this is what we really try to reconstruct when we're doing an MUCL reconstruction. It then can become more complicated and, maybe a little too academic is dividing this into multiple bundles. As you go along, you start to kind of understand that these bundles are really just any joint or just additional thickenings that people have, taken biomechanical studies or cadaver studies and just transect and say, hey, that has an important part of stability. So it's all just the capsule, it's thickening of the capsule. It has an anterior, central, and posterior bundle. And I think if you just look at your elbow on your own, just see how the elbow moves across the range of motion, that understanding the anterior bundle would be tightened extension, the posterior bundle would be tightened flexion, and the central bundle, it's right in the center. So it's the most isometric. And we talk about isometric points quite a bit. Big test fodder is when does this ligament get stressed the most? And it's really in that late cocking, early acceleration phase. You got to imagine that's when the pitcher is most reliant on not only full external rotation of the shoulder, but starting to sort of unwind that valgus, or really wind up that valgus moment on that elbow to give you that extra snap, and then accelerating forward and pushing that elbow through there. And the big thing with the pitcher elbow is you'll hear them. It can be an acute pop, but it can also be sort of a loss of accuracy, velocity, and control. And usually that acute pop is sort of felt in the later stages of throwing. It's not necessarily where the ligament is most stretched. It's they feel that pop right at the end. So also too, these elbow injuries can be treated based on how the tear actually occurs. So the ligament itself can be detached humeral, intersubstance, or ulnar, and different authors have suggested treatments in different ways for that from non-operative treatment. It also depends on in season, but whether you want to treat this based on the location of the tear, the acuity of the tear, and also the degree of the tear. So these will come up in some of our studies here as well. And a little higher level stuff is talking about, PRP and other adjuvants for surgery in this. So surgeries can take a bunch of different forms, and we'll sort of go over that in a few of these studies too, from the original Job technique of taking down the whole flexor pronator mass, reflecting that, and doing 2 tunnels over the ulna with a bone bridge, as well as a tunnel through the sublime tubercle and stitching that graft together, to more modern docking techniques or even suture button techniques. And we won't really talk about it, but there's also acute repairs of this ligament, which was focus of one of the quarterbacks this past season who did tear his. But again, that sort of separates how valgus instability is really unique to baseball pitchers versus different overhead throwers. So I think we'll get into the studies now.
Thanks, Dr. Macfarlane. We'll get into right into one of the cornerstone studies when it comes to valgus stability in the field of orthopedics. Again, this is Jalen, third year at Ohio University College of Medicine. First study we're going to talk about is the valgus stability of the elbow, a definition of primary and secondary constraints, done by Mori et al. In 1991 and was published in Core. Give a little background to the study at the time. Understanding the stabilization structures of the elbow joint, particularly their role in resisting valgus stress, was previously poorly investigated at the time. Previous investigations had primarily focused on calculating force displacement curves, but with those curves and the approaches to that, they had limitations in replicating real life scenarios when looking at patients. Thus, the clinical question of what is the contribution of the radial head and the MCL to the normal kinematics and constraints of the elbow during activity had yet to be answered. And thus, their aim was to address these limitations by examining the contributions of the MCL complex and the radial head to elbow stability during active motion and when muscle activity was applied. This study consisted of 6 anatomic specimens that were used in the primary study, 2 left elbows and 4 right. The protocol revolved around stimulating motion and joint compressive forces to apply mimic muscle activity. They used a 1 kilogram load to biceps to mimic the biceps and a 2 kilogram load to mimic the triceps, which represented about a 5% of the maximum potential forces that these muscle groups usually could cause. They also used the valgus stress to apply to the elbow to mimic the effect of gravity on the arm. The elbow was tested from full extension to 140 degrees of flexion, and this protocol was verified using 2 separate specimens in initial pre-testing. 6 additional specimens were used to collect additional and detailed information. 3 were examined with an absent MCL complex but an intact radial head, and other 3 were examined without a radial head but an intact MCL complex. 3D motion of the ulnohumeral joint was described about 3 axes that you can see in figure 2 on the right: flexion, extension, abduction, adduction, and axial ulnar rotation. When looking at the results, they used a series of graphs to express the different Y and X values that they were looking at. So in figure 3, this is demonstrating a peak mean of 5 degrees of normal valgus laxity had occurred within a normal elbow, and this typically occurred between 10 and 20 degrees within the normal elbow. In figure 4, this showed that in the valgus gravity stress position, internal rotation of the ulna during flexion averaged about 2.8 degrees and was of greatest magnitude between 20 and 40 degrees of flexion within the normal elbow specimen. In figure 5, with elbow flexion, both abduction and internal weight rotation had changed very little when the radial head was removed or when there was a release of the posterior portion of the MCL complex. However, when the entire MCL had been removed after the radial head had been resected, gross instability was observed in both the abduction and axial planes within figure 5. Looking at figure 6, this is demonstrating that there was no change in the valgus or varus or axial rotation when there was an absent radial head. There's also no change observed when only the posterior bundle of the MCL was then resized and released. In figure 7, this is demonstrating that the release of the posterior MCL with an intact radial head had showed minimal abduction displacement, and moderate displacement was observed with subsequent anterior bundle of the MCL release. Lastly, marked displacement had occurred when the radial head was then secondarily removed. In figure 8, release of both bundles of the MCL resulted in internal axial rotation of about 9 degrees from 60 to 80 degrees of flexion. Secondary release of the MCL and radial head have resulted in greater internal rotation and gross instability shown by external rotation of the ulna during 30 to 100 degrees of flexion demonstrated in the graph. Lastly, in figure 9, when muscle load was applied, this tended to restore stability to baseline after an MCL release. However, when both the MCL and radial head was removed, muscle load only restored stability to that of an MCL deficient elbow, demonstrated in figure 9. In all, the study found that the radial head was a secondary constraint and did not significantly contribute to elbow valgus or axial rotation stability when an MCL complex was present. However, when the anterior bundle of the MCL complex was absent, moderate laxity had occurred even with a present radial head. The study also showed that simulated muscle activity reduced the valgus laxity and caused by the MCL release, but did not fully restore stability. Thus, at the time, the findings suggested that the radial head may not need to be replaced with a prosthesis in cases where the MCL and the DRUJ was intact to restore stability. However, in situations when the MCL disruption was present, the radial head did play a significant role in resisting instability, justifying its preservation or internal fixation rather than excising and resecting it. Thus, understanding the roles of these structures helped inform operative management at the time, particularly in cases of radial head fractures and MCL disruption.
All right, so I'm Alex Macfarlane. I'll be talking about the reconstruction of the ulnar collateral ligament in athletes. So this is Frank Job's early study in '86 regarding the success of the ulnar collateral ligament in athletes. So what they did is they recruited or retrospectively reviewed 16 athletes between the years of '74 and '86. These were all males between the age of 20 and 31, so all pro or college athletes. This was 12 pro pitchers, 5 of which were in major leagues and 7 of which were in minor leagues. 1 college pitcher and 1 pro outfielder, 2 javelin throwers. So again, this is a pretty unique injury to a very small subset of patients. 8 of these 16 patients recorded an acute event of rupture. 9 patients had a history of steroid injection, and 5 had a history of a prior surgery. 1 was a MUCL repair. Others were flexor debridements, elbow debridements, loose body removal, etc. So this is more or less them reporting the actual procedure that they performed. So it was a full reflection of the flexor pronator mass, which you can see in the figure here, illustrated by the authors, with removal from the medial epicondyle and obligatory ulnar nerve transposition, which comes into play. They mentioned one of their complications being in ulnar nerve palsy, and they largely attributed that to not transposing the ulnar nerve. However, now more recent studies don't support necessarily that. It's probably to do with their technique as well. They used autograft, autograft in all cases. So mostly ipsilateral palmaris longus, which is still common this day. Plantaris in 3 patients, and Achilles autograft in 2 patients. Their technique were 2 converging bone tunnels on the medial epicondyle at the point of the isometric landmark. So again, that anterior inferior landmark. And a single bone tunnel on the ulnus of the tendon is sewed together in a figure of 8 fashion. The flexor origin was then repaired to it. So you can see in that figure the final graft with the ulnar nerve transposed anteriorly. So looking at the results, you have overall a pretty large follow-up. Again, all these patients are baseball players, about half of them receiving steroids, all of them within the age of 30. They did have several complications, but their follow-up, from the first patient, 117 months to 2 years in at least every patient. All of these, all except 3 patients were competing at the time of the completion of the study, one of which competed for 1 year and then retired. He did have 2 prior operations and had a long duration of surgery, or a long duration of symptoms for 96 months. The other competed for 4 years, retired, which I would consider to be a success, depending on the patient's age at the time and desire for that. And they had also had symptoms for several years. And another competed for 2 years and only had steroid injections prior to that. So overall, this is just a preliminary report of really Job's early technique for this, which is often used. And you can see how the modern generation of these surgeries change over time, as we'll see in some of these other studies, from not reflecting the flexor pronator mass to using different techniques of anchoring the tendon, autograft, as well as different ways of managing the ulnar nerve.
Okay, great. Thanks, Alex. This is Matt, segueing into the next article published in JBJS in 1992. Once again, coming from the Carolyn Job Orthopedic Clinic. This article was titled Medial Instability of the Elbow in Throwing Athletes, Treatment by Repair or Reconstruction of the Ulnar Collateral Ligament, and it was published by Conway and colleagues. So just to go over some things that were already elaborated on. So as we know, the primary constraint that resists valgus stress is the anterior oblique band of the ulnar collateral ligament. These throwing activities lead to enormous valgus stress in the elbow, especially during the late cocking and early acceleration phases. This results in repetitive microtrauma from overloading, which causes inflammation and microscopic tears of the ligament, which ultimately lead to weakness and occasionally rupture, leading to instability of the elbow. So at the time of the study published, Repair and reconstruction were two operative ways to manage the tears of the UCL complex, and the authors of the paper usually performed a reconstruction approach, although they did note direct repair of acutely torn ligaments can be appropriate in some patients, which we'll discuss later. So as a result, the authors sought out to assess the results of repair and reconstruction of the UCL in throwing athletes, and then also identify the factors that affects the results and outcomes shown. So continuing out the study design shown, this took place between September 1974 and December 1987. They included 71 patients with valgus instability, which was confirmed torn or incomplete tear of the UCL during operation. They included 67 baseball players, 3 javelin throwers, and 1 tennis player. And then 68 of the 71 patients were followed up, or 96% were broken into 2 groups, including the direct repair group, which included a total of 14 patients, and then the reconstruction with autologous graft tendon, which included 56 patients. It's also important to note that 2 patients in the reconstruction group had poor results after previous repair, thus they underwent a reconstruction, so they were included in both groups. This study was particular to high-level throwing athletes with chronic use, so we can see that Major League Baseball pitchers, minor leagues, high stress in the elbow throughout the season. Then they were followed up in an average of 6.3 years. And then this follow-up consisted of history and physical with valgus stress testing, ready-ref imaging with valgus stress in the elbow. And then as previously stated in previous articles, but all the patients had similar non-op treatment prior to the surgery, which included various modalities, including rest, oral NSAIDs, supervised stretching and strengthening programs, and PT modalities. And then just to round it out, they noted that all groups had the same post-operative care routines, very similar in terms of what they do to return to play. So looking at the population as a total, the repair group once again had 14 patients. All were male with a mean age of 26, and they were all baseball players. All had no previous operations, and 10 of the patients reported an injury during a single throw. The mean time from injury to operation was about 7.6 months. The valgus stress test was positive in 8 out of the 14, and this demonstrated instability during physical exam. All but 2 patients had pain on palpation of the UCL complex, and then all 14 patients had direct repair of the anterior bundle of the UCL without augmentation. And then there were some concomitant procedures included, such as transposition of the ulnar nerve, osteophyte debridement, and calcification removal. So looking at the reconstruction group, as we said previously, had a total of 56 patients. 55 were male and only 1 female. 52 played baseball, 3 were javelin throwers, and 1 professional tennis player. The mean time at the age of reconstruction was 24, and then it was just a little bit higher at 27 for the Major League Baseball players. 9 patients, or 16%, had previous operations, and this could included a myriad, including transposition of ulnar nerve, repair of the UCL, as previously stated, arthroscopic removal of loose body, diagnostic arthroscopy, and debridement of osteophytes. Also important to know that 34 patients had the injury on a single throw, and 22 were unsure didn't remember such an event. The mean time between injury and op was about 12 months, so a little bit longer than what the repair group showed. And then valgus stress test was positive on 33 out of the 56. And then all but 2 patients had pain on the palpation of UCL. And then so since this is the reconstruction group, in terms of graft selection, palmaris longus tendon was the most commonly used graft. 15 patients had ipsilateral and 30 patients with contralateral, and then plantaris tendon and the extensor tendon for 4th toe was also included in some other patients. And then all patients but 1 had anterior submuscular transposition of the ulnar nerve, as shown before in other studies. So when they described the results, they first started with seasonal occurrence, and they showed that 48% of the baseball players had injury occurring during spring training of the first 2 months of the season. And this was very similar for Major League Baseball players. So looking at the top right figure, we can see that during the April and May months at the beginning of the season, both had 5 injuries during that time period. pretty much greater than all the other months. And then in terms of the relationship of pain and the throwing and the phase of throwing, pain was most commonly seen during the acceleration phase as well as the follow-through phase. And we can see the phases of the overhead throwing athlete there. Once again, acceleration causing the massive valgus stress in the elbow as expected. And then in terms of operative findings, they found that the ligament was involved distally in 7 patients, approximately 2 in 61 patients had a mid-substance tear. And then 27 had calcifications of that ligament. And then 11 had large osteophytes shown during operative examination. And then 10 out of the 18 without instability had calcification. And then once it was removed, they then demonstrated instability. So looking at postoperative physical exam findings, with the 41 patients that were examined post-op, 8 of them had a repair and 34 had a reconstruction. When they were looking at physical exam findings, they were mainly looking at loss of extension. So extension to 0 degrees was not possible in 4 patients with repair and 17 patients with reconstruction. Loss of extension to 5 degrees or more was shown in 2 patients with repair and 9 with reconstruction. And then loss of extension greater than 10 degrees was shown in 6 patients with the reconstruction. But what's important to note is that out of the 4 out of the 6 patients who had the flexion deformity, they still showed excellent functional results, which we'll talk about later. And then lastly, they looked at postoperative radiographic findings in the patients who returned to pre-injury level of sports. Stress radiographs demonstrated a mean opening of 3 millimeters in the repair group and 2 in the reconstruction. So when they reported the results, they used a results rating scale, which included subjective terms considered excellent, good, fair, and poor. And these were all basis on the return to competition. So excellent was deemed that the patient was able to compete at the same level than before the injury for more than 12 months. Good was defined as a patient was able to compete at a lower level for more than 12 months or was able to throw a daily batting practice. Fair was the patients that were able to play regularly at a recreational level, and then poor was if the patient was unable to play at all. So in terms of previous operative treatment, this included the all repair group. Previous operations drastically decreased the chance of returning to play a previous level of sports participation. This was statistically significant, as shown in figure 10 on the right. We can see that 74% of the people with no previous surgery deemed the results as excellent versus 33% deeming excellent with previous surgery. And then on the far right of the graph, we can see poor, not being able to return to play. 33% of the patients with previous surgery deemed it as poor. In terms of the type of procedure, excellent or good was reported in 10 of the repair versus 45 or 80% in the reconstruction group. So we can definitely see that people were deeming it excellent with the reconstruction. In terms of previous return to previous level, 50% had the repair versus 68% who had reconstruction shown in figure 11 deemed it as excellent. So once again, reconstruction having higher levels of excellent return to play. And then this was shown to be even greater with statistical significance on the major league level, 65% with reconstruction and only 29% with repair. And then in terms of post-op complications, 15 patients developed neuropathy, which was transient in 6, and 1 was unable to return to sport, and then 9 had additional operations in which 4 were then subsequently able to return to sport. So overall conclusions, the authors really showed, when do we consider repair? They showed that acute injury with no ulnar nerve symptoms, and the operation was soon after injury, and the UCL was normal except for complete separation from the bone at origin or insertion was a time to consider repair. They also wanted to highlight what they used to reconstruct with. The results obtained with different grafts were similar, but the authors preferred ipsilateral palmaris longus tendon. And then overall, they showed that with reconstruction of the anterior band of the UCL, most athletes are able to return to previous level of sports participation. And then finally, the chance of returning to competitive level of sports is reduced when prior operations preceding the reconstruction are taken.
Awesome. Great job so far by everyone. As we'll kind of see, kind of these last couple articles have some overlapping themes, but that's okay because obviously repetition is key in these. Um, Also, for anyone that's still listening and hasn't caught on yet, they're just listening on the podcast form, there is a video version of this as well on YouTube, which has all of the figures that we're kind of referencing as well. This would specifically be a good one to watch and kind of look at the different figures and surgical images as well. So the next article we have is from Rohrbaugh et al. Talking about medial collateral ligament reconstruction of the elbow using the docking technique. This is out of the American Journal of Sports Medicine in 2002. So again, just some general background. A lot of this we've heard already with the great introduction from Alex and also the other papers that we've discussed. But again, the medial ulnar collateral ligament, common injury in overhead athletes, primary restraint to the valgus stresses during throwing. Typically treated with the free tendon graft. A lot of the ones we've seen, the preferences to use the palmaris longus tendon, and then you reconstruct it in humeral or ulnar bone tunnels, as described by Job, which was Alex's paper as well. Again, we can see the initial technique kind of on the right side here on my screen with the figure of 8 technique. Kind of using that technique and building on it. Obviously, these were all early iterations. So some of the issues that they noticed with the Job's initial technique was that the strength of the suture fixation of the free tendon graft, whether they had adequate tensioning of the graft at the time of final fixation, as well as potential complications resulting from detachment of the flexor origin. And then they were worried about 3 large drill holes in the medial epicondyle leading to possible stress fractures, and then routine transposition of the ulnar nerve. They weren't sure if it was contributing any significant difference. And concurrent interarticular pathology seemed to be an issue as well with some loose bodies. So these issues kind of led to these authors proposing a new take on Job's initial, which they refer to as the docking technique, which we'll talk about. So the goals of this new technique were multifold. First was to perform a tendon graft reconstruction of the MUCL, specifically in the muscle splitting safe zone approach. So kind of taking the same approach, but they wanted to avoid the obligatory transposition of the ulnar nerve. They felt like that wasn't contributing a ton to adequate patient outcomes. They also wanted to routinely arthroscopically assess and treat interarticular pathology conditions, particularly in the posterior medial elbow compartment of the elbow joint. Again, if there's any loose bodies, other things of that nature, they wanted to put a scope in there, make sure there was nothing else going on while they fixed the MUCL as well. They again wanted to place the tendon graft in bone tunnels. That had worked well. And they wanted to reduce the number of humeral drill holes from 3 to a single hole, thus reducing the invasiveness and then possible complication again of the epicondylar fracture. And then lastly, they wanted to simplify the graft tensioning and improve fixation methods. So the study design for this is a single surgeon retrospective review of their records from October 1995 to February 1999. So again, this is an older study based off of the initial study from Job, which was even earlier. This study population only had 36 athletes, all had symptomatic MUCL insufficiency. They were confirmed by MRI and then again intraoperatively. The average age of the patients was 23, ranging from 15 to 57, with an average follow-up of 3.3 years. Again, most of these, like we have talked about, are the overhead throwers. So 33 of these were baseball players. There was 1 lacrosse player, 1 tennis player, and 1 golfer. Average time of fixation from symptom onset was about 2 years, 24.5 months. And again, as we talked about with a lot of these other studies, the ipsilateral palmaris longus autograft was used in the majority of these cases, 34 of 36. So this is again where if you're watching on the YouTube video, this would be helpful. There's a lot of surgical images up here. But so they started their procedure by doing an arthroscopic eval of the elbow joint, making sure, again, looking for intra-articular pathology, things that wouldn't normally be seen in traditional just MUCL repair. And then they would go and harvest the palmaris longus tendon. And then they would make an incision over the medial epicondyle, preserving the antebrachial cutaneous nerve branch of the median nerve. And then they would take a muscle splitting incision, go through the flexor carpi ulnaris muscle, and then getting down to the submuscular exposure of the MUCL, assessing the joint laxity after they had made the incision. Then they would create the ulnar drill tunnels. They used a curved curette in their ulnar holes, and then a single humeral tunnel, as mentioned prior, instead of those three that they had were initially proposed by Job. Then they used the pretty similar techniques again, kind of to Job's. The posterior limb of the graft was docked into the humeral tunnel. Elbow was reduced with the varus stress and final tensioning of the graft using a Krakow stitch. And then the anterior limb was passed into the humeral tunnel. Sutures from both limbs were tied over the bone bridge and secured the graft. So their results, unsurprisingly, obviously, if you're already taking a well-described technique and kind of trying to make your own improvements and publishing them, probably did pretty decent. But 45% of the patients had osteophyte removal. 2 of the patients underwent ulnar nerve transposition. Again, this is something they didn't want to do routinely, but if they felt they needed to, they did, which happened in 2 of these. Those were due to preoperative diagnosis of ulnar nerve instability or compression. 33 of the 36, 92% of them returned to or exceeded their previous level of competition for at least 1 year. So again, pretty successful. All 22 professional or collegiate athletes returned to or exceeded their previous competition level, and really not a ton of postoperative complications. So they had 2 large ones, one wound hematoma, and another with mild paresthesias in the ulnar nerve distribution, both of which resolved at 3 weeks without intervention. 3 patients overall had what they had described as poor results. One had a new diagnosis of reflex sympathetic dystrophy. Another had a fracture of the ulnar tunnel during batting practice, which I thought was pretty significant. And then the last one was unable to achieve sufficient power while throwing. So the conclusions from this paper was that the docking technique, this new technique based off of Job's initial one, allowed for simplified graft tensioning as well as improved graft fixation. It seems like their overall goal of, a stress fracture from reducing the tunnels may not have necessarily helped. Obviously, a small sample size with only 36 patients, but one of them did have it with, I would consider, relatively low intensity exercise with batting practice. But they did say that athletes of all skill levels can expect a high rate of return to their previous level of play. And then again, previous success rates can be matched and even improved using the docking technique modifications. So again, kind of seeing this evolution of, building on a known surgical technique and then kind of making modifications or tweaks. And we kind of see this a lot in this MUCL repair.
All right, this is Teja, and now I'm going to be talking about our final study here, which goes again in the outcomes of ulnar collateral ligament reconstruction of the elbow, specifically from the team in Alabama, Dr. Kane, and published in the American Journal of Sports Medicine. All right, some quick background again. So the anterior bundle of the UCL is the primary restraint to valgus stress, like we talked about, and specifically during flexion from 20 to 120 degrees. And injuries are most often occurring in overhead athletes, so again, baseball players, or patients who have acute elbow dislocation. And the main symptom they complain about is, again, valgus instability given its anatomical function. And Dr. Job, like the previous studies have shown, pioneered this reconstruction procedure and first performed it in a pitcher known as whose name was Tommy John. And the image in the left kind of shows you the surgical procedure where you're replacing the torn UCL with a tendon graft, most often the palmaris longus or hamstring tendon. And specifically in this study, the reconstruction was performed either with the palmaris longus, gracilis, or plataris tendon graft, and an ulnar nerve transposition was also performed. The steps of the procedure, like we mentioned, involves protecting the ulnar nerve and transposing it if it's at risk, and then removing all damaged UCL ends, and drilling tunnels in the ulna and humerus for the graft, and threading the graft in a figure-8 pattern through these tunnels and appropriately tensioning it in order to restore the elbow stability. So this specific study was a single surgeon retrospective review of patients who had this procedure done between 1988 and 2006 and who had a minimum 2-year follow-up. And the diagnosis was, again, confirmed using an elbow arthroscopy where valgus stress was applied specifically at 7 degrees of flexion. And the anterior lateral viewing portal was used to see if there was any joint space narrowing, and anything greater than 2 millimeters was confirmed as positive. And like I mentioned before, the graphs, the distribution in terms of which were used were 73% of the surgeries used the palmaris longus tendon, 23% used the gracilis tendon, and then a toe extensor tendon was initially used in one of the initial procedures on only about 3%. And outcomes that were collected were what percent of these patients returned to play, and at what competition level. Was it collegial or a high school level or professional level? And they also recorded the complications and number of revisions. And so between those years of 1988 and 2006, over 1,200 patients had this procedure done. Predominantly 98% were males and 98% was on the dominant side. And 95% of these patients were from baseball, of which 89% were from pitchers. So you can see kind of the population is mostly predominantly male baseball players who injured their dominant throwing hand. And the average mean was about 21 years old, but had a distribution from 14 to 59 years. And 32% played professionally and 48% at the college level. And in terms of patients who actually had outcomes recorded, 942 patients had outcomes, of which 743, or about 79%, had a 2-year minimum follow-up. And of these patients, they experienced pain, 96% of them, during the cocking and acceleration phase of the throwing, which we explained previously how that is tied with the injury. And surgery was performed at an average of 7 months after symptoms began. Initially, patients first had to confirm the injury and also underwent rehab for about 3 months. And if they failed to progress, that's when consideration for surgery was applied. And 34% of these patients also received an excision of an electron osteophyte. Those were related to increased stresses of valgus extension overhead in the face of valgus instability. And so here were the results. Remarkably, 83% of patients returned to their prior competition level or higher. So they were able to get back to the level of their performance. And in terms of the timeline, it usually took about 4 months for patients to be able to start throwing, and about 1 year for them to return to their full competition level. And no differences were found in terms of which graft choices or if the electron osteophyte excision was performed. So it seems that any graft and the presence of these osteophytes are able to adequately be treated and allow patients to return to their play. And in terms of complications, the most common complication was post-op ulnar nerve neuropraxia. and predominantly it was sensory paresthesias that were experienced in their ring and small finger, and these tend to resolve in 6 weeks, and it occurred at a rate of 16%. And another complication was graft specific to the graft that was used. About 4% of patients predominantly had a superficial wound infection, and this was resolved with antibiotics. And so the conclusion of the study showed that the UCL reconstruction is a pretty successful procedure to treat valgus instability in athletes, and about 83% of these athletes are able to return to their prior level of competition, regardless of which sport or skill level. And in terms of the complication rate, it's a 20% complication rate, but mostly minor. Like we mentioned, the temporary ulnar nerve neuropraxia or superficial wound infections that are able to be treated with antibiotics. Some limitations to keep in mind is, again, the population that we looked at, which was predominantly, like I mentioned, young males who play baseball and are pitchers, which is where this injury most commonly occurs. And the follow-up rate was 79%, so there was an inability to get complete data where 21% of these eligible patients. And there was no outcomes of the physical exam in their follow-up or no radiographic follow-up data. And although you're able to measure the return of play, there's no specific elbow outcome scores in order to quantify how each patient feels in terms of their patient-reported outcome measures.
All right. Well, that wraps up our episode on elbow instability. Hope that you guys learned a lot. I know that this was an awesome episode for me to help put together. Even learning about this more as an intern, it can be a confusing topic for sure. And I will likely go back and re-listen to some of these findings if I ever need to again. So thanks again, everyone, for your help on this episode, and hope everyone listening at home likes it as well.